Thank you guys for joining us today on this webinar about PDPM and nursing's role. Let me just introduce myself for a second here. I am a 27-year nurse with experience. I started out as a CNA many years ago. My background in skilled care is anything from a DON to an MDS nurse to an administrator, a regional nurse consultant. I've also worked in acute care as acute care floor manager in private practice, a branch manager of home health and hospice, and just in some other settings, but that's enough about me. Let's get to what we're here to talk about today. Patient-driven payment model. A lot of us were practicing when PPS began, and was it scary? Yes. Was it exciting? I thought it was exciting too. But as we talk about October the 1st, a patient-driven payment model, how is CMS going to let a patient drive payment? The reality of it is they are going to utilize that initial 5-day initial payment assessment to see the characteristics, the comorbidities, the signs, the symptoms, the diagnosis, and how the patient really presents to determine that patient-driven payment model daily rate. So we know it's going to utilize those coding elements inside the MDS as really the sole determiner of payment. ICD-10 diagnosis codes also will impact. We know that the primary ICD-10 will determine what category the patients fall into for all of the PDPM categories. We know that there are 5 categories with PDPM, the PTOT, ST, the non-therapy ancillary and nursing, and 3 of these are affected by a variable per diem rate. What is that? So using a constant daily rate, it allocated too few resources in the beginning of the stay when costs are really higher with therapy and drugs, and too many resources at the end of the stay when costs tend to be lower. So a variable per diem rate is going to impact 3 of the 6 components, the PT, OT, and the NTA, the non-therapy ancillary. How? So for PT and the OT components, days 1 through 20, there's no factor applied, no variable per diem rate. But then on day 21, the rate adjusts down 2% every 7 days. Now, the other variable per diem rate that's affected is the non-therapy ancillary adjustment factor. So they're saying for the first 3 days of your Medicare stay, you're going to get 3.0 of that. So 3 times that rate for 3 days. And then days 4 through 100, it drops down to 1.0. So definitely they have recognized that patients are more acute and needing the therapy more intensely at the beginning and possibly a higher return on some expensive meds and those type of things. We know that inside a full MDS, it's a 52-page MDS, and they're not going to use all of those questions to drive this payment. It's going to be anywhere from 130 to 159 of those entries. So we definitely want to make sure whoever is determining the correct answers on our MDS, they're at the best, most accurate rate. Now, just hot off the press in the last month, we've always called the initial MDS the 5-day assessment, and it's still going to be that initial 5-day assessment. But CMS is now calling it the initial payment assessment, constantly changing. So let's talk about PDPM and nursing's role. And when I think about PDPM, I do get excited. You'll tell I get excited and I talk faster, but it's because of the years being a nurse. And when I'm thinking about how are we going to, in nursing, be prepared, I'm thinking about the MDS nurse coordinator and the floor nurse. So if we first look at this nurse assessment coordinator, the MDS nurse, currently right now inside our buildings, they are the person who is determining your ICD-10 code for the MDS. So right now, how those are coded on the MDS does not change payment. But October the 1st, it's going to determine payment. So we do want to make sure that whoever inside your facility is doing this gets the required training to not just be competent on doing the MDS, but understanding how to utilize ICD-10 codes and getting the most accurate one of who the patient really is. I know that across the United States, we have numerous extremely competent, very experienced MDS nurses. But MDS coding and ICD-10 coding are two totally different activities, and now we're going to expect our MDS nurse to do both of those. So where's the challenges with this? The reality of it is we know that nursing turnover and nursing leadership in skilled facilities really doesn't have a longevity. Celebrate if that's not a problem for your facilities. But the reality of it is sometimes that position is open and it just becomes that unit nurse that is sharp and reliable, and now they're in the MDS department. And where they've seen them, they've never really completed them. So when we're talking about this position with that frequent turnover, we really need to be very aware of what kind of characteristics we're wanting for who is in this position. Do they have experience with not just MDSs, but have they gotten a little PDPM training? Are they fluent in knowing how to code something with ICD-10 codes? Do they meet these qualifications? Because we do know there's not a lot of people who have those experiences, and to get them trained would be intensive and costly. So as we look at this position, we're looking at what is the current MDS roles and how will it change with PDPM. So right now, our MDS nurses are over the top busy with setting ARD dates and making sure the interdisciplinary team is completing their MDS, their CAUSE, their care plans. But as we transition, we're going to be decreasing the amount of MDSs completed. Our start of therapy, change of therapy, end of therapy, 30, 60, 90. We'll still have to do regulatory 90 days, but there will be less MDSs to complete. So the focus will not be on the volume. The focus will be more on the accuracy of this initial payment, MDS. So they will be more responsible for actually doing ICD-10 coding, determining what the primary diagnosis the patient is there at the skilled facility. We know that Section GG is going to have to evolve with PDPM. Currently, we know that therapy is really completing Section GG, and CMS is really encouraging. I was at a meeting in April, and CMS was there. It was the ANAC National Conference, and one of their hot topics was Section GG. What is the usual performance of the patient in their first 1 to 3 days before we begin treatment? Usual performance at 10 in the morning and 2 in the morning, drastically different. So CMS is encouraging that GG becomes a collaborative effort between all shifts of nursing and therapy. So definitely the MDS nurse is going to have some oversight of taking that information and determining the average usual for Section GG. I always think about this MDS nurse and their responsibilities with this importance of this initial MDS to verify you've got the documentation for what you're claiming. We've always said if you don't document, you didn't do it. But now with claiming all these diagnoses on the MDS, the reality of it is we need in the chart for it to reflect it. So simple things like the documentation of swallowing disorder. What symptoms did they present? It's going to fall to that MDS nurse to teach and lead this interdisciplinary team as they're documenting and ensuring everything that they need is in it. Dietary and social services both document. They both have a section within the MDS they complete. The reality of it is the documentation reflecting what we're claiming? We know that the BIMS and depression assessment that social services does is their documentation from that social service department in a note of what they found. And does the nurse also have some documentation of cognitive decline or recall or memory issues? I do believe we'll be looking at this comprehensive medical review of the whole history. Currently, I know everybody doesn't get what they need from the hospitals when they're getting records to do a comprehensive medical review. So it's going to be that MDS nurse declaring this is what I need from the hospital to get all the comorbidity diagnosis as far as this When I think about the MDS nurse also, we're talking about this IPA, interim payment assessment, that we will be looking at. So the IPA basically is an optional standalone assessment. CMS has been very clear that you don't have to do one, but it does authorize payment for the remainder of a PPS stay. So it does not affect that variable per diem rate. So to realize the staff has to determine when or when not to complete it. Is there enough return and impact on the payment to compensate for the time it's going to take to do one? So I do believe that this will be a role of the MDS nurse responsibility oversight with assistance from the floor nurse and the team. The other thing that CMS has come up with is the interrupted stay. Now, because of this variable per diem rate on those first 3 days for that NTA, there was concern that it could incentivize our providers to discharge and readmit patients to reset that variable per diem rate. We know those frequent readmissions don't assist our patients, so CMS, to mitigate this process, introduced the interruption stay policy. Now, this is a 3-day window referred to as the interruption window. It starts with the calendar day of discharge, and it includes 2 days immediately following. So if a resident is discharged from the SNF and readmitted to the same SNF no later than 11:59 p.m. of the third consecutive calendar day after having left, it is considered a continuation of the previous stay. So the effect of the interrupted stay, the assessment schedule continues from the point just prior to discharge, and the variable per diem schedule continues from the point just prior to discharge. So I do believe the MDS nurses' responsibilities will be monitoring for these IPAs and the interrupted stays to stay on top of those. So when we're talking about challenges with coding the MDS, what's an active diagnosis is not any different than it's ever been. The Resident Assessment Instruction, RAI manual, instructed us many years ago that it's a twofold step to determine what's an active diagnosis code. The first one is, has the physician or some doctor or diagnosed this in the last 60 days? 60-day look-back period to see if actually documented diagnosis. And the second step is it active? An active diagnosis would be one that has a direct relationship to the resident, current functional, cognitive, mood, or behavioral status, medical treatments, nursing monitoring, or risk of death during the last 7 days in that look-back period. So the guidelines of determining if something is active has not changed, but it's going to be not just us determining it, but can we prove how we determine it? You know, currently we talk about denials, and really therapy has taken the ball by the horn because they're the ones who are saying they're skillable and their documentation is under scrutiny. With PDPM, however we code the MDS and how it's documented will be more under scrutiny. So if we want to make sure we know how we determined it was active and where we got the information. And then the second step is, does our nursing documentation reflect what we're saying on the MDS? So we know that if it's not documented, it's not done. So definitely it will lead us into more education, teaching our nurses, ensuring they're documenting what we're claiming. This screen here is truly a snapshot. I think financially the impact of specific parts of the MDS is easier to see when you see dollar amounts. So if you look at this screen, and I'm not going to go over all of it, but if you start at the top, you see in depression, D300 is a depression assessment. If their score is 10 or above, on average, this is someone much smarter than Brenda came up with this, we would see an increase of $28.51 a day to that daily per diem rate for your patient. You see, just being cognitively impaired, it's not a specific score on the BIMS, it's just cognitive impairment, is worth around $14.59 a day. Swallowing issues, you see that just the symptom present, not a diagnosis, not a modified diet, just a symptom present, is worth $15.24 a day on average. This makes me think about how many patients inside your nursing homes take their medicines in applesauce pudding, something like that. We know it's a standing order in most SNFs, so they're not usually even diagnosed with a swallowing issue. So CMS is recognizing that we do interventions just for a symptom, 15, 24 a day, every day on average. Then if you roll down and just sort of look at those IV fluids, we know that with our ARDs currently on this initial assessment, 5 days, they're usually on day 7 and 8 because we're trying to get therapy minutes. But with PDPM, the PTOT and ST therapy minutes won't drive payment. So we're looking at that initial MDS ARD date to be day 1 or 2. That way, that look back period can include 5 or 6 days in the hospital, and you'll be able to count the hydration IV fluids. So for those people that are dehydrated and UTIs, it is an opportunity to access that. Look at the returns on IV fluids meds high. On average, 98.35 a day increase, and low is 42.15 a day increase on the daily rate. So it is an average, but it gives you an idea of the importance of each one of these questions that we're coding them correctly. Who can diagnose? You know, we always talk about who can diagnose, and 15, 20 years ago, there weren't physician extenders. Now we look at, we've got nurse practitioners, we got physician's assistants, and all of them can diagnose. We also can use diagnoses from that clinical nurse specialist, that wound specialist at the hospital that writes those wonderful notes and takes pictures. That's an appropriate diagnosis that we can access. The other thing is also on the radiology report, the MRI, the chest x-ray, those are all read by a physician, usually not who's caring for the patient at the hospital, but you've got a physician's signature on the bottom of them, so the diagnoses on all those reports are accessible too. I do want to touch just for a moment, some hospitals on their discharge summaries will put diagnoses current and diagnoses resolved. So sometimes the hospitalist says the diagnoses that are resolved, in their mind at the hospital they might be, but they might be truly active. This is let me give you an example. So the patient was admitted with a COPD CHF exacerbation and a lot of other comorbidities. They're coming on the discharge summary, it says these are resolved. But they come to us on 4 liters of oxygen, on nebulizers every 4 hours, and they can't lay down below 40 degrees, their head up on the bed. So the reality of it is this is an opportunity now, before October 1st, for us to possibly have our medical director or our primary care physician who oversees your patients to maybe touch base with these local hospitals and explain that this resolved means they're still getting treatment. Is it truly resolved? Or the other way to do this is just to, as someone is admitted, call the nurse practitioner for your primary care physician and say, the hospitalist wrote that the COPD exacerbation is resolved. Would you mind giving us a current COPD diagnosis? Because truly, they're coming and we're going to be doing respiratory treatments and assessing lung sounds and checking pulse oxes. So communication with your primary care physicians or your medical director and their physician extenders is going to be very important as we go forward, ensuring that we have all of the appropriate, correct diagnoses. Where do we find them? This is just a list when we're talking about what is the MDS nurse truly looking in to find these diagnoses. So, the H&P, the emergency room records, hospital records, one thing that you don't think of currently that you need, but you will be needing in October and you could broach now, is the hospital medication administration record. Why? Because as we start reverting these initial assessments down to the first few days and wanting to count IV fluids, we have to have proof of them. And it's a lot easier to get off of a hospital MAR than to read every consult note for current medications of the day and have to look and look and look. So know that this is something that you could start working on right now with your local hospitals, getting an MAR for every single day they were at the hospital. Discharge summaries, again, all of those reports from the hospital, from radiology and CT scans and MRIs. Surgical reports are also really good, especially when you're trying to get a specific diagnosis for a fracture, because it gives you very much detail of what was broken, what appendage, what end of the bone, and what type of fracture. And then, of course, transfer records and consults also provide you some good. What we don't want to do when we're looking at this is we don't want to code something from a symptom in a nurse's note. Many times the nurses will document patient was admitted with this diagnosis, and it's the only nurse that documented that diagnosis. Everybody else said they were admitted from somewhere else. We know that we cannot use any nurse's signed symptoms as a diagnosis. We also cannot use any diagnosis that's added by a PTOT or speech, unless it's on order and it's like generalized weakness, blah, 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 and then it gives the treatments, and the physician, it's an order for a treatment regime with the diagnosis. Then when the primary care physician signs that, then you've got a diagnosis. So it is a possibility when the MDS nurses are doing their MDS to see if therapy has gotten their orders back and signed, then you could access those diagnoses on that telephone order. You know, we really never want to guess or assume what the doctor really meant. I think that's why that relationship with our medical director and their physician extenders will be very important. I mean, it's something I would even take the time to, at one of your monthly meetings with your medical director, to talk through this with him. So now let's talk a moment about the staff nurse. How can we get the staff nurse ready for PDPM? This scares me as an old DON and a regional nurse, because the reality of it is we do have turnover in our nursing departments. And we know that we have to get everybody up to the same level of documentation and knowledge, because now the nursing notes will be reviewed for proof of payment. I mean, I'm thinking about RAC audits and just a little bit scary when I even say the word. So let's talk about how can we get our nurses ready for PDPM. The idea of it is once this initial determination of the reason the patient is coming to the facility is determined, this diagnosis is the primary diagnosis for the stay. And the whole interdisciplinary team and the floor nurses need to know what that is, because we need to not just know it, they're going to need to be documenting it and what's required for it. So if it's a pulmonary patient, we're going to be looking for daily pulmonary assessments, pre and post nebulizer treatment, lung sounds, and pulse oxes in the middle of the night. You know, and does our documentation reflect that? Does our nurses have the skills to document for cardiac patients, for orthopedic, for senile dementia? So all of those care paths are diagnoses groups we really want to make sure our staff is knowledgeable about. Now, there are also some other diagnoses besides the primary that come to my mind. We know in the non-therapy ancillary section, Medicare is giving us a little bit extra money for some specific diagnosis. Example, morbid obesity. So if we're claiming that as a diagnosis that we're putting in the I-8000 line, we want to make sure that there is a note that reflects it, which could be as simple as the admission note saying, Mr. Smith, blah, 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 he is admission weight of 410.55. There's your documentation. So we really want to make sure that not just this primary diagnosis, but all of those other ancillary diagnoses in the NTA section, we're having proof within our documentation. Now, I really think there's one very large opportunity for every skilled facility, and it is in the respiratory program. So we know that over many, many years, as long as I've been a nurse, nurses, LPNs, RNs have been doing nebulizer treatments and the handheld MDIs and not being really paid for them. We also know that it's a pretty expensive medicine when you're looking at expense for medicines. But with this, there is an opportunity. Respiratory therapy can drive payment with PDPM. We know that the rules in the Resident Assessment Instruction Manual has not changed about what counts for respiratory therapy. So let me just give you a snippet of it. Respiratory therapy, only minutes that are provided by a respiratory therapist or a respiratory nurse that they spend with the resident shall be recorded on the MDS. For PDPM, it needs to be 15 minutes a day, 7 days a week, and then it can pull a higher daily rate. So, what is a respiratory nurse? Again, Appendix A in the RAI manual. A qualified professional respiratory nurse must be proficient in the respiratory modules, and I'm not going to read through those, as above, trained either through their formal nursing education or specific training. So this is an opportunity for every skilled facility if they could choose to actually utilize respiratory therapists, but they could choose to ensure they do some education with their nurses, competencies, get them in their personnel files, and start documenting this now. So we're already in the mode of counting who has had 15 minutes a day at the patient bedside to instruct the patient what they're doing, lung sounds before, administer the nebulizer, lung sounds after, and then we would get reimbursed for it. So I do see this is a very large opportunity right now for all skilled facilities. I know that TMC has a respiratory program and even an educational component that's available. The other thing is with IPAs, the interim payment assessment, how will the MDS nurse know if the staff nurse does not alert with a change of condition? We've been focused on change of condition since rehospitalization kicked in about 8 years ago. So interact and change of conditions are going to be still on the front burner, because when somebody's condition changes, then we're going to have to look back and say, do we need to do an interim payment assessment, or has there not been that much of a change in their care, or what that rate would be? What else are we going to work on with the staff nurse? We know that restorative nursing does have a financial component for the two lower categories of the nursing component that will increase the daily rate. So do we have an active restorative program that we don't pull the restorative aide to ride the van or give showers or work the floor when somebody calls out? Can we figure out how to do that? TMC has a solution for that also. Section GG is really a section that we talked about earlier that will be determined really by all caregivers on all shifts, not just therapy. So we're going to have input from that staff nurse around the clock of what is that usual performance. How is Section GG communicated collaboratively? And then when we're talking about Section G and Section GG, currently our nurse aides have a very important role in Section G in determining ADL scoring. Section G, we know at some point will go away and we will be left with GG. And CMS hasn't announced that, when that's going to be, but they've indicated it will be at some point. Section G itself, the scoring of it, 0 means you're independent and 4 means they're totally dependent. But yet on Section GG, 0 means you're dependent and 6 would be independent. So it is a reversal of order. So definitely in the next couple quarters, we will be seeing some needed education when we start accessing CNAs to assist us in GG on the difference in coding. And then just again, nursing documentation. You know, I look back as a DON and you always had this 2 or 3 people that when they did an assessment, it was the most wonderful nursing note. A lot of people right now with admissions do checkboxes. I think we will drift away from checkboxes and go back to that narrative nursing note, because you can provide proof and not just a check. So look inside your internal teams and who is that stellar nursing documentation person, and maybe let them help be part of that champion to get our floor nurses truly ready. I appreciate you all, and thank you guys for being here with me today. Next month, we are doing a webinar on PDPM and census development.